Hello and welcome to another podcast by the School of Surgery entitled Enhancing Your Surgical CV. My name is Dr. Naomi Laskar and I'm joined today with Mr. Lund.
Hello.
And Dr. James Blackwell.
Hi there.
So, just to introduce the aims that we're going to talk about today. So we've got the audits, presentations, prizes and competitions, research and publications, courses, exams, teaching, leadership, logbook and interviews. So let's kick off. Audits. From my own experience, I've heard that if you can do a couple of audits as a med student if you very organised and you manage to, but otherwise I've heard that when you're an F1, F2, try to do one audit per rotation. Is that what you found, James?
I think the F2 requirement when I just finished F2 was that you had to do one audit and you had to present it. Ideally, you close the loop on one. That can often be really difficult in a 4-month attachment. I think that if you're very efficient, then you can get one done in each rotation, but possibly it's better to concentrate your time on doing one really quality one or two over a year period, ensuring that you close the loop on both of them, as opposed to trying to beat one out every single attachment that you do, because there's always a lot of lead-up time to starting an audit and then finishing one, and before you know it, you're on to your next job. And actually, it's really difficult to go back and spend the time data collecting or getting hold of your seniors that you need to help you to finish the audit.
Yeah, well, it does take a time, doesn't it? Because you have to have it registered with the audit department, come up with the idea, talk about it, come up with the protocol, go to the audit department, have it signed off, and then there may be some time collecting the data, etc. It does take quite a while, and so you're not going to start it, in your first 4 months maybe, because you're just settling in as a doctor, aren't you? And after that, so it does take quite a while. I would say completed cycle audits do count for a lot more in selection processes, and it's probably a lot more satisfying because you've seen something and you've intervened and hopefully made it better, which must be better. I think one of the other things is if most F1 and F2 jobs are divided up into 4-month blocks, and 3 of you go around a year. So if you can join up with the other 2 on that particular rotation, you can go around and finish each other's audits off, and it's mutually beneficial. So I think a bit of teamworking can help, but those sometimes a little bit tricky to organise.
What sort of topics would you suggest?
I think that the topic necessarily isn't that important. Getting an achievable audit that you can finish is the most important thing. When you start doing research and audit, you want to be really autonomous, but actually I think you have to take the lead from your seniors, and you have to see how it's been done before and ask for their advice the whole way through, because otherwise you'll end up in a dead end spending a huge amount of time that comes to nothing. And I think you'd be surprised actually if you get onto a good project or a good audit, it can be quite easy to achieve a presentation or a poster or something, whereas if you plug away blindly with not really knowing what you're doing, then you can waste an awful lot of time. Guidelines come out all the time in different areas, and you can always audit against those guidelines, because the likelihood is that your clinical area isn't going to be quite up to speed with a brand new guideline that comes out. And things that generally irritate you in the workplace, or you don't understand something about what it seems to be inefficient, you can audit against that and see whether you can make maybe a service provision or make the service slightly better just by your own observations.
Yeah, so service improvement's another thing as well, isn't it? So it's slightly different to audit, and you can look it up online and see what different definitions are. But you can do really short service improvement with a PDSA cycle. You can look that up.
I was going to say,
but it's very, very, very easy to do. So service improvement will tick the same box as audit.
Yeah.
And so that NICE are always bringing out new guidelines in whatever area, and other professional associations, Association of Surgeons or Association of Gastroenterologists or Association of whatever, and when they come out, it's an opportunity to do an audit, because your department won't be up to speed, or it would be very unlikely, and then you can intervene and make it and bring it up to speed, and that'll be quite satisfying, I think, to do that. But the ones I've done over the years, the one where I've gone around and something's really irritated me. I thought, why do we do it like this? This seems so inefficient or so wrong, and then because no one's thought of it, you get a lot more out of that. It's something that you appreciate. I think the bottom line is, though, if you can't think of anything, you go to the audit lead in your trust, and there will be rolling audits. So, one of the ones that's always rolling is VTE, prophylaxis, weekend plans, checking of results, AKI, things like that. So, will be rolling audits that you can get involved in if you, just to get you going, with the process. So it's not too hard. But I would say at the beginning as well, like with all these things, try and think it through. You probably don't want to do the 47th VTE audit in that trust where you aren't going to be able to present it anywhere that's going to be of value to you in terms of gaining extra skills in presentation. So you want to have something that's quite new, quite topical, that people will enjoy hearing about, be interested in hearing about, so you can take it to a regional or a national meeting and present it as a poster or a podium presentation. So you improve your presentation skills, you get the presentation together, you get an abstract, and you get a publication. You go to somewhere where the abstract is going to be published. So you can kill quite a few birds with one stone at the same time, enjoying doing something useful as well.
I think you've quite nicely gone into our second topic there, which is about presentations. I think first and foremost you can present any audit that you've done, and that's a good way of getting a presentation under your belt as well. But what other things, James, do you think we can present?
I think it's important to know that there are different levels of presentation out there, from posters to oral presentations, but the conferences change as well, in that there are medical student-specific conferences, and your first opportunity would be if you've done an intercalated degree and you have a BSc. Some of the research that you do there is really high level, and that should be your first CV bolster. Nag your supervisor, and you can at least get a poster out of it, take it to a medical student conference, and you've shown already 18 months in advance of becoming a doctor that you're interested. You're going to go down the academic path and you're going to build your CV early. Then moving into sort of fourth and fifth year, I was fortunate to attach myself to a really productive registrar, which is a minefield in itself. You have to find somebody that is productive and attach yourself to them, and also at the same time prove that you're productive, and then that opens doors for you. And then you want to kind of attach yourself to a piece of their work that's going to go to a national conference, international conference.
Do these count for different points, the national and international? Yeah,
I think so. On the point scheme, once you get to core trainee or academic foundation programme, they do. So aim high and aim big, and you have to do a bit of nagging and things and try and get people to submit these things. But if you're prepared to do a bit of the legwork, then that always helps.
Mr. Lund?
Well, yeah, I think that's it. So first, pick your supervisor, pick a person with a track record. I mean, I think I see a lot of people who go to somebody and have some massive idea, and it never comes to anything because it's impractical. You can't get the data, or it's too big in scope, or it takes too long to collect or to do, or the intervention just runs over a long time. So go to someone who's got a good track record of turning around things for people at your stage. And that might be different. Some people are very good at having, supervising PhDs, but not very good at supervising or having small projects for people doing medical students or F1s or F2s. So have a look, ask around who's been good, and then go and see them. But go and see them, looking keen with a bit of an idea, or saying you'd really like to do something, and then get involved in something else. And in terms of getting things ready for publication, count back from when the conference is going to be. So identify something online. Say, right, okay, well, I need that to, and there's a submission date. So I need to have something written up a couple of months before that, so that the supervisor can have a look through it and chip in and correct things and offer some suggestions, and then data collection back from that. So you might be a year before the conference when you need to start the project. So all these things, you can't turn up and say, I'm going to enhance my portfolio 3 weeks before the interview. All these things need a year or 18 months or even 2 years running. You ought to be constantly thinking about what you're going to do. And then, so medical student conferences, Association of Surgeons in Training, that's a national thing. Look for something where the abstract gets published. So you can have a published abstract as well on your CV. And national and international conferences. So there'll be a regional society whenever specialty, not just surgery, but any specialty, have the regional society where the bar's a bit lower there. And then national and international things, most things count. A national meeting, national association meeting is the same as an international one. You don't have to go abroad. And in some ways, it's actually quite easy to get into some of these because I suppose cynically, it might be about bums on seats. They need to pay for the conference, so they need other people to attend.
Yeah.
And so, and some of the poster presentations now, particularly with electronic posters, can be enormous.
Yeah.
And so you can get into these things and score quite easily with not earth-shattering work.
I know some people get quite bogged down with having to have a publication before they go to, whether it's core trainee jobs or registrar jobs. How important would you say that is?
I'd say that for core training, probably not too much at all.
Yeah.
I think you've just shown you've done something through core. Most people come out of foundation year looking very, very similar, and so to put a bit of clear blue water in between you and the other people at the interview, it's quite easy to do. A presentation, a completed loop audit, and perhaps a published abstract is going to put you in the top few in the portfolio. When you're thinking about portfolio, we're going to cover everything else. It's about the spread as well. There's no point having a Nobel Prize and nothing else. Because you're only going to score in a research block. And I think the other thing is what I would say about people who become obsessed with portfolio for selection, and a portfolio is only a smallish percentage of the marks. And for most selection processes, you could probably turn it without a portfolio and still get easily selected as long as you're a very sensible, safe doctor at that. So most of the marks are for the clinical performance, and with some of the marks, perhaps about 20% at most in the portfolio section. So don't get too bogged down.
I think that is one of the key things to mention, is that don't get too bogged down with the portfolio. And I think it's about 75% of it is just weighted on the interview itself, isn't it? Yeah. But we'll come and touch on the interview again towards the end. I know there are quite a few courses out there, ATLS, basic surgical skills. How important is it to have these done?
So I took the approach of I'm interested in surgery. I want to get into theatre, like all interested people do. So what was the first course that was going to be useful was basic surgical skills. It's a college affiliated course, so it counts. So that's something to bear in mind as well, is that some of the courses don't count quite as weighted as others. So you need to go for the mainstream ones. And then, so I did that in F1, and it was really handy actually. And then when you go to theatre, you don't feel like a klutz and you know what you're doing a little bit. Then moving forward, when I started to think about ATLS, I thought it'd be great because I could get an extra point on my portfolio. But the reason I didn't do it was, one, it expires after 4 years. 2, it's quite expensive. And 3, clinically, I'm not really in a position where I'll be using the core principles that you learn about leading the team and everything in an ATLS environment. And I think that there are probably other courses that you could go on that you might use sooner. Like undoubtedly I need to do it at some points. But just depending where you go, I know there's some people that did it very early, and I suspect they'll end up doing it again before they even really use it. And so probably think that through. There's a couple of courses that you can't do until your CT, so you don't need to get worried about that. And the one that's on my horizon now is the core lab skills course. And I think as soon as you start building those skills, that's probably the earlier the better.
So I'd agree with that. I mean, for surgery, the 3 big ones are ATLS, basic surgical skills, and the care of the critically ill surgical patient, CRISP course. And so at some point you're going to need to do those, either because it's a mandatory curricular requirement, or exiting from MRC from core training, or it's just CRISP good for looking after patients on the ward as well. And then I think other things, your educational courses are important, and they're often quite short, and some of them are free. Your university might offer them for not very much, and they're very good, and will score in courses, but also might count towards any educational components of the portfolio, and also make you a better teacher and make your teaching experience better. And just while I was talking about education, what I forgot to mention in the presentations thing, that educational conferences are wide open to people presenting work there, and are very encouraging of people and developing. So education conferences is something to think about. So you needn't just think about research as something scientific, it's all the stuff you do as a doctor.
Do you think the conferences are a good place to get prizes as well?
Well, if you're lucky, yeah. I mean, I think there's not that many prizes knocking around, but there are. There's a lot of opportunity for prizes. So prizes will count. So if you've, prizes and awards. So if you've got a first in your intercalated degree, or you get honours in your BS or equivalent, if you can, get a prize for coming top in the year or top in one of the modules. But you can't really plan for those. You do well or not, you get a prize or not. I mean, there are lots of other prizes around that, if you enter them, then you stand a reasonable chance of getting them. I don't think lots of prizes are oversubscribed. So there might be, at your medical school, a lot of prizes around that if you write an essay for, or do a small extra exam for, you might be able to get. And they may be pretty dusty and not very well known, but they look just as good as any other prize on the CV. And similarly, there's lots of other medical organisations that offer prizes. So the BMA, the MDU, the MPS, the Women's Medical Federation. The Royal Society of Medicine has a whole heap of prizes. So just have a tour around their websites and see what's on offer. And some of them are very well subscribed, and I suspect that some of them aren't very well subscribed. So if you're not in it, you can't win it. And I think what you have to do is weigh up the balance of how much effort you're going to have to put in versus the reward. So if it's write a 10,000 word essay, you might want to do that. But if it's write a 2,000 word essay, then you might want to do that.
I think on that point, there's if you kind of peruse around and find yourself 6 or 8 essay titles, the chances are one of them you might actually be interested in, or you might see that you'll get a lot of benefit out of researching that. So if you're keen, then it's going to help, and it doesn't need to be dissertation length or standard. A lot of them I entered one. It was, what's the surgeon of 2050 going to look like, or what's the new shape of surgical training. Some of them are quite good just for you to put your thoughts down on paper and put your side of the argument to somebody.
Right. I think one of you touched on the exams and MRCS briefly. When would you say is sort of the optimal time to sit the MRCS? Like I know, James, you were talking about sometimes things are better to do later on. Would you say that's the case for this?
I think in hindsight, I sat mine at the first rotation of F2, and I happened to be on an academic placement then, which possibly gave me slightly more time, or more sociable time to revise for it. In hindsight, I'd advise people to sit it as soon as you feel ready to revise again after finals, because it's really quite close to what you learn for finals. It's not much of an extension. There's some new things, but the new things are the things that are exciting to learn if you're going down a surgical route and you go through different suture types and different things like that, and the stuff that you want to absorb that knowledge, but the rest of the knowledge is actually stuff that you've just clogged yourself with for finals, and the longer you leave it, the more of that you're going to lose. So going back to revision was surprisingly nice, actually. Going back to a bit of learning, because you spend...
Did you ever think you'd hear yourself saying that?
No, I didn't. You spend all of F1 tearing around the place and you don't really look at a book. And then to go back and you feel like you're subspecialising and you're looking just into surgery and away from the things that possibly you're not that interested in. So I would sit part A as soon as possible, and then part B, I spoke to different people. I think I'm just keeping one eye on the fact that you might need to work a few jobs to confidently go through the clinical stations.
Would you say that having experience being on the wards would help you for part B quite a bit?
Well, I haven't sat it, but that's what I've heard.
Yeah.
And I think that's the approach I'm going to take. Because it's difficult with head and neck or breast and things like that you don't get very much exposure to at all at medical school.
I think for any exam, sit it when you're ready, and make sure you're ready, because first thing is expensive, and the second thing is terribly demoralising.
Having said that, I've heard some people say the best revision for their exam was having failed the first time.
Oh, well, must be better at bouncing back than I am too. So I just say do it when you're ready. It's just very expensive to do, and I think the other thing is, when you take an exam, particularly with the Viva component, it's all about practice. So a clinical examination thing, do it with some friends that are doing it, and Viva each other, watch each other examine, and the exam itself won't be as bad as your friends. Your friends will be horrifically cruel to you, take you apart, and so the exam itself will seem like a walk in the park. But like all these things, it's about learning the skill, so it becomes almost automatic when you do it in the exam, because you'll be anxious in the exam and forget stuff, and so the more automatic all these things can be, particular examination skills or causes of, or what I would do in a trauma call and things like that. So rehearse these things so it becomes, at least the first couple of sentences become almost automatic, or the first part of the examination you can concentrate on what you're actually feeling rather than whether you should percuss or auscultate next.
I think that's a good thing probably to do soon after your med school finals then, because it just reminds you of being back in medical school then. Sitting exam after exam, isn't it?
I think that it comes back again to planning and timing, because medicine's very prescriptive actually, the way you work through it, and you can look through your medical school max and know what you have to do by the time that you pass out of that, and then you can look through your F1 curriculum criteria and the sign-offs that you have to do. Equally, you can look at the person specification for core training or registrar, and you work back from there. If you're a pessimist, then you probably want to be sitting your part B of your MRCS 2 in advance of when you have to have it to become a registrar. Some people leave it right till the end and try and pass it first time. Equally with your part A, if you want to get it done in the first half or second half of F1, then it gives you a bit more time to fit in your part B. But the other thing you have to bear in mind is it'll be the first time that you go on to working nights or a surgical rota, or you're stuck on MAU, that sort of thing, and you also got to have a life, and you got to have your Christmas holidays, and you got to have your Saturday nights and things, and there's a lot to juggle. So you have to be prepared and don't feel too rushed going into it.
Yeah, but also I think at that point, don't leave it too late, because you want to leave yourself at least one go in reserve. You can't exit core training without having MRCS, and it's a shame when people left it a bit late and they take it just once and don't pass, much to their surprise, or take it a couple of times and don't pass. So it's about timing it right. Don't do it until you're ready, but make sure you're well prepped when you do.
So let's go on to talk about teaching. So there's quite a few medical students and junior doctors that do informal bedside teaching, but from my own experience I know that as however useful that is for med students, they don't get feedback forms, which doesn't show anything on your portfolio, unfortunately. So I think one of the key things I would say is it's make sure that you devise your own feedback form and get feedback for what you do. Is there anything else that you guys want to add?
So teaching's really enjoyable. You get a lot out of it. So do it. It is one of the things expected of you in duties of a doctor. You're supposed to teach other more junior doctors and medical students, and it's very rewarding. But get feedback, like you say, and then. But I think if we just come to selection or building your portfolio, just delivering bedside teaching or small group teaching, everyone's supposed to do that. It's not going to get you very far in terms of marking if we're being a little bit cynical about it. But also what develops you as a teacher, I think, is doing a bit more than just a bedside teaching. So developing a course to deliver a series of lectures, and then going on a short teaching course, or if you've got a bit more time, a certificate in medical education. And these kind of things, which aren't that hard to do. They can be online, but again, they do cost a bit of money. I think you do have to think about how much money you're expending. Enjoy it, I think, the first thing with teaching, and then try and develop yourself as a teacher. And also that you get feedback, but also if you think of something new, or develop a new online module or something like that, or it's a slightly new way of delivering the teaching, then research it, put out a questionnaire, how did it do, what do you think about this compared to the other one, and then you can present it in an educational meeting.
And it's good, you can link in all these things and actually do things that you actually enjoy, which is a nice way of having to tick these boxes, so to speak.
Yeah, I think you touched on there that like technology and things that advance, and thinking about new technology and how you can use it is really interesting. For like, this is a podcast, and 10 years ago people probably didn't know what a podcast was, and there's video like vodcast, and it's not reinventing the wheel, but when you look on your university website and all the videos, there's somebody dressed like that from the 1950s, where you can say, well, I can revamp it and I can add a bit of a modern twist to it. All the science is still the same, isn't it? But it can all be delivered in a different way. So I think there's scope to redo those things. Yeah,
I think I've seen from my own experience from my medical school, there was quite a few old videos that we watched and felt like revamping. Now let's go on to talk about leadership skills. So I know that from the person specification, there's an entire box for leadership.
Yeah.
What can you suggest to our listeners about how to develop their leadership skills and how to demonstrate it?
I don't know. It's hard to find. James, you have a go at defining what you should do. That's leadership, you see. Delegation is my key leadership skill.
Leadership is difficult, isn't it, really? But the easiest way to do it is to use examples that are outside of work. But it's difficult within work because when you're a junior, you don't really feel like you're a leader because medicine's so hierarchical in some circumstances. But actually, if you can kind of cross some of the boundaries of the specification in that if you're teaching and you can set up a course, then by definition you're kind of leading and you're leading from the front, and then the people that you're leading are the medical students. If you're on the ward and you're conducting an audit to make your ward better, then you might find yourself in a position where you're leading HCAs, you might be leading nursing staff, you might even be leading your seniors if you're pointing them in the right direction and highlighting things to them that they don't really see in their roles currently. Then there's other things that you can join, so you can join committees and you can join patient safety groups, things like that. It's all stuff to pad out your CV, and important at the same time. I know that there are certain personalities that really get into the committees and into the BMA and the junior doctor working group and things in the hospital. You have to decide if it's your cup of tea or not. But again, you only have so much time, and it's tempting to sign up to everything. But figure out what you can do, what you can enjoy, and what you possibly might make an impact in. Yeah.
So these kind of things are often leadership, management, and teamwork all sort of bundled together. So not just about leadership, but I think that's it. First, do something you're going to enjoy. There's no point sitting on a committee where you can't stand the subject and you're bored to tears. But you can get involved and you can make a change. You can do something and suggest a change and make a change, and and that feels good when you do that. It's important, I think, to get some sort of these kind of skills, because later on you will be involved in, or you'll want to be involved in decision making, and these are often nearly always made through committees. So you got to get good at it. It is another skill about working a committee, about getting your ideas across to other people on the committee, about how to manage that, chairing committees, etc. So I think the first thing you do is organising a rota. Could be something that you do. That's a kind of a leadership thing. Perhaps the local M&M meeting, an audit. Get your audit and organise a meeting. Have one and organise a meeting for your colleagues to have the hospital audit meeting that you led and organised and chaired. And then the local trainee groups, so the BMA is one thing, but if you're an F1, there might be on the F1 board, there might be an opportunity for a hospital representative from the F1, F2 community, or core trainee on the local core training committee, the School of Surgery, or equivalent in the specialties, and you can go from there, be on asset or equivalent like that. So everybody there's lots of things where you can be represented, and you might enjoy it.
So one of the other things I wanted to touch on was about logbooks and surgical logbooks. So I was told that when you start F1 and F2, it's good to, if ever you get a chance to go to theatre, just to keep it online. And there's a website called elogbook.com or .co.uk.
So I've done that the whole way through, and it's free to use and free to sign up. The only thing that you don't get on that is any validation. So I think there is a way that you can find different consultants, but nobody's on it. It's not like a proper portfolio where you can ticket somebody and get it signed off. So it's all done in good faith. I think that if you turn up with 200 operations and don't know what you're doing, then you'll kind of be found out. The way I do it is I log everything, whether that's camera holding or actually performing a skill myself. When you're a junior, you might get to the point where you're allowed to close or you're allowed to do clips in the skin, for example. So then I would put laparotomy. There's a little note section at the bottom. I'd put the date, all the criteria that they want, and then I'd put laparotomy, and then I'd put things performed by me, and I'd say skin clips to skin. And then you see over weeks to months to years, and then those things slowly build up, and then you say, actually on this one I opened, this one I closed. Nobody's going to expect you to be doing operations on your own. but before you know it, there'll be abscesses on there, and then there'll be 20% of appendix you've done, 40% of appendix, and you'll get there eventually. But until you're a core trainee and you have the ICP portfolio, you can't really log everything.
That's done through e-logbook.
Is it?
Yeah.
Okay.
Yeah. So I think e-logbooks. So I'm not a shareholder. I'm no vested interest here, but e-logbooks, I think the way to go. And the other really good thing about it is that you have an app for your mobile device. And I think two things about that is it helps you enter the data at the time and the notes that James says, but also it avoids you getting into any potential scrapes with confidentiality. So you enter the date of birth
offline as
and
well,
the hospital number, use it offline, offload it later, so you don't have to go around with a list in your pocket, which you might by mistake leave on the bus in the pub, and then it gets sent back to the hospital and suddenly you're in a lot of trouble. So I definitely recommend that. And then, when you go in, opening and closing the abdomen will be a massive thing when you go to core training. People haven't started that. You can do it in foundation, do some abscesses like you say, and assist at some appendicectomies. You might even be able to do part of it, if it looks okay and you've been a few times. So I think get involved in theatre. I think one of the things that people don't do when they're in F1 and F2 is go to theatre. I think they have to sit on the ward and just or sit in the mess, and you get much more out of the job. The more you put in, the more you get out. So if you go to theatre and turn up and you get involved and the people let you do stuff, your mantra should be, I think, can I do that? People aren't going to let you do stuff if it's not safe, but they'll probably forget that you're there. They're allowed to let you do stuff. So even starting with the skin, can I put the skin clips in? And can I help open the abdomen? Can I help close? Can you show me how to do half? And just be politely sort of assertive. Yeah, well, it's reminding you there, and you're the trainee, and it'll be good for them to help you along. But yeah, get involved, keep a record, and like James says, you would be surprised how quickly it all mounts up in the logbook.
One of I think one of the last things I wanted to touch on really is about the interview itself. So I know it's held in around January time, but I think, James, you're going to come up to it at some point soonish.
I think that there's prep that you can do for the interview, just as you do for your finals. So I know people that have been through it, and you have to get all your examinations nailed down. There's a plethora of books and things preparing you for CT interviews or preparing you for registrar interviews, or just as there is medical school finals and things. And you can go through them. There's certain popular online banks of questions, a couple of big ones, and they're useful to work your way through. You can't get away from the fact that you need to practice. One of my strategies is going to be, I think, from medical school and as a junior, you know who the good teachers are because they know the examinations inside out, and they can teach them. So one of my strategies will be to teach every single examination that may well come up. So I haven't done an ENT job, but I think if I can confidently and competently teach some students to do an ENT examination, I think that will stand me in good stead, rather than just practicing with a mate.
I think teaching is a very good way of learning, actually, because it really tells you what you don't know, especially when students ask you those questions.
Oh yeah. So it crystallises your thoughts, doesn't it? Because I think everyone knows the answers, and it's all like soup in your head, but it just comes out in a random order unless you've said it a lot. So it helps you be a lot more organised, which gives a much better impression of you at an interview. And in an interview, you won't have to examine anybody or anything like that, but it's all about. But there are lots and lots of common things that come up. So a trauma scenario, an acutely ill patient in some way, some sort of resuscitation thing, and communication skills, of course. They recruit now for NHS values, and so you have to demonstrate that you're compassionate and honest and transparent and can communicate well with people. So all these things come from being good, and that's what the selection process is meant to do. And also selecting for those things, so you're demonstrating those things. But practice with people. Identify somebody from the year before who did really well. Everyone knows their rankings. Everyone will quietly just mention that they came third in the world or whatever they came in, and say, how did you do it? What did you do? And I think the other thing that for any job in or outside medicine is have a look at the person's specification. It's always online. And there are essential and desirable criteria. And the essential ones are things like, are you a medical graduate? Are you currently a felon? And do you have the
Can you speak English?
Yeah, to a certain level, but not particularly, not all that well sometimes. And then desirable criteria. What you want to make yourself do is that describes the person they want to employ. And what you want to do is make yourself look as close to that person as possible. And so have a look down there, see what the kind of things you want. But you need a year, 18 months, even 2 years to get yourself to that place. So the more you can look like that, then the better the chance. If you turn up looking exactly like the person's specification, especially the desirable criteria, then you're home and dry.
So as we're coming to a close, if James, if you had to give your younger self, whilst applying for surgery, if you had to give them one piece of advice, what could you say?
It'd be about planning in advance, and you need to start thinking about this at third year medical student level. And the reason you do it is to give yourself choice. And I think that with no planning, you may well get onto core training, and then you might get through core training, you might get to registrar level, and you might get a number. But if you want to have the choice, and this is something they don't explain to you when you go to medical school, if you want choice of where in the country you work, which hospital you work in, then you really have to CV build really hard from the very start. And actually choice becomes more and more important as you get older. And that's a wise head passing on wisdom.
Mr. Lund?
Yeah, I think that last point's very true. So you can, so I think core training, you might get on. Higher training is a much more difficult hurdle. And so I think, if you start well, get into good habits, then you'll carry it through, and certainly go through core. Don't just sit on your laurels when you get in core. Is just keep gradually. Don't kill yourself, but just keep gradually doing it. Pick up skills as you go along, and think ahead. So what do I need to do for next? So have a word with the people a bit ahead of you. How did they do it? And then copy some of their behaviours. But basically, just be keen and enjoy it. Have a good time. I think the thing that James says about choice is very important though. So you can come to selection, get selected, but the only number is left is somewhere where you don't want to work particularly, and so you might end up going there just to have the number. And the higher up you get, then of course the closer to your first choice you're going to get. So it's worth putting in some work and being good and practicing and stuff. So you need to come high enough. So particularly if your partner is in a particular place, or you want to be near your family, or you both want jobs in the same region, then you've got to do things like that. But on choice of region as well, the other thing is that if you don't want to go to a particular part of the country, don't put it down, because sure as eggs is eggs, that will be the place where there's a slot for you. So if you don't want to go to London, or you don't want to go to Yorkshire, or even who wouldn't want to come to East Midlands? Everybody does. But if you didn't want to, don't put it down, because you'll get sent there. So just be careful what you choose, and only put the things you actually want to go to.
Yeah. Well, thank you very, very much. And just we'll summarise now. So for audits, presentations and research, essentially pick something that you are interested in, really, and try and link them all together. If you do some research, if you do an audit rather, you can then take it to a conference and present it there. And when it comes to exams and courses, try to time them right, is I think the key advice from us, really. When it comes to leadership, do something. You don't have to pick a specific role. Choose something that won't be too much work for you to do, given that there's so many other things that you're going to have to do at the same time, such as starting a new job and rotating from place to place. But you can display leadership qualities on the ward just by doing very, very simple tasks, and just keep in mind that you should update your logbook as you go along. You can download this app that Mr. Lund's been telling us about, and remember to talk about all this in your interview when you go.
Absolutely. So they're not psychic, you've got to tell them.
Yeah. So, thank you very much.
Thank you.
Thanks.
Thank you for listening to another podcast brought to you by School of Surgery. Remember, you can follow us on Facebook at School of Surgery, on iTunes, on Podomatic at schoolofsurgery.podomatic.com, and finally by searching School of Surgery on YouTube. Thank you very much, and see you next time.